that will be maintaining the size of the structures properly. Whereas in a bucky out image, the quality, exposure quality would be better, but the size of the structures would not be proportionate. I think we have discussed about that. The divergent rays from a single point, when they are acting upon the film, you will have the sizes of the structures towards the periphery, which may become somewhat disproportionate to the normal. So what you will see is in a case of bucky in film, the first one is bucky in film, you will see that the sizes of the structures can be easily assessed and they can be measured. You don't see that there is a change in the variation in the size. Whereas in the bucky out film, if you look at the end of these clavicles or the bones, you can see that peripheral end of the clavicle seems to be much wider than the medial side. The lateral side seems to be wider than that. Or even in the ribs, it looks like the lateral portion seems to be much wider than the medial side. So this is the effect of the bucky out. Now, but bucky out film would have better clarity about the bone shadows, whereas in the bucky in film, the bone shadows are not so clear because the number of rays passing over the film would be lesser in case of the use of the bucky. So this about the bucky being used and how it can be affecting these shadows, quality of the shadows. Now, X-ray images are not always perfect. There is always a scope for error. In this case, you can see a shadow of a key chain which corresponds to the middle mediastinal area. And in the lateral view, AP and the lateral view also you can make out that there is a shadow. But there the common sense separates. A key chain really, if it is swallowed and then it's in the esophagus, it cannot remain in this kind of a position. This key chain actually is kept over this X-ray socket, and then the X-ray was taken just to show you the impact of the images. So many times these images can be misleading. If somebody says that this key chain is in the esophagus, you cannot just say that he is absolutely wrong. But if you know the real situation and a matter of common sense, if a key chain is swallowed, it cannot have this kind of a position where two key will be above and two keys would be below. That kind of a position is not possible. And we know that it was kept placed over the cassette. So when you interpret the shadows, there is a limitation. There is always a possibility of some errors, and hence many times you will have to need more images, more views to confirm about the position. Of course, this also we had seen one example. Now another example of the effect of the erect and supine position. In the erect position, the extension of the lung, the expansion will be more. You will be able to see the whole length of the thoracic cage being slightly more than the other way. And the mediastinum shadow, the width of the mediastinum would be lesser than the supine position. The supine position, the diaphragm will be slightly displaced superiorly. The position of the diaphragm will be slightly superior. And the total width of, or total length, the height of the thoracic cage seems to be slightly lesser, whereas the mediastinum becomes wider. So impact of the position also would be quite significant. Whenever you see some external objects, like these external objects have to be identified properly, whether they are present over the surface of the body or whether they are present over the cassette or so on. Now in this X-ray, you find an opacity which has a typical classical appearance of a cardiac pacemaker. A cardiac pacemaker kept over the thoracic surface with its cable wire over the area. In the lateral view, you can see the same shadow, the pacemaker shadow, and the wire placed over. So this can make out the evidences. So many times you have to have a common sense, like what could be the object. That shape of the object also has to be known as such. Now, foreign bodies, when they are present in the shadows, again, you need a lot of common sense to make out, like whether the bodies are within the lung tissue or outside the lung tissue, and so on. There can be lots of confusion. You have an image here, and in such a situation, multiple views are necessary. Multiple views. Now we have AP and lateral view here. If at all necessary, you may have to have a oblique view also if necessary. In this case, you can see a metallic shadow, a needle-like shadow, a pin-like shadow is seen. Now, whether it is in the lungs or whether it is over the abdominal wall or so on, it can be confirmed only by a lateral view. With the lateral view, it can be confirmed that this is over the lung tissue in the lower lobe. So, a pin has been aspirated into the lower lobe. That's how it can be diagnosed. Now, X-rays also could be useful to make out the position of the nasogastric tube. When you insert the nasogastric tube, usually in the nasogastric tube, the end of the nasogastric tube, you will have a bubble or a ball-like structure which keeps it radio opaque, and there is a blue lining over the tube. That blue lining also gives you that radio opaque shadow so that you can monitor the nasogastric tube. So when you have inserted the nasogastric tube and has gone into the stomach, it can be confirmed with the X-ray. Whereas if at all there is some error and the nasogastric tube has gone into the through the bronchus and entered into the lungs, which accidentally occurs, and many times it occurs quite frequently in the clinical practice too. And that itself, the nasogastric tube itself, could be a cause for the lung damage. The atelectasis and the lung damage can occur. So this can also be made out. So whenever we say a foreign body, this also could be one of the issues. My purpose of showing all these images is just to condition your eyes to the views of the X-rays, not more than that. Similarly, a patient who had undergone thoracotomy surgery where the sternum is repaired, you may have a metallic wire which can be persisting. So some of the common foreign bodies which could be seen, and these ring-like structures are the wires of the sternotomy surgery. So the moment you look at it, you can make out that the patient had undergone a sternotomy operation. Now, in addition to these extrapolations or artifacts, there could be the other way, abnormal calcifications in the body. Now, in this patient, you have a subcutaneous calcification. Now, these are the artifacts of the ECG poles kept in the ICU, the wires and the ECG poles kept over. And you have an area of opacity, and this area of opacity, you may get confused like whether it is in the lungs or whether it's over the surface of the body. Now, this actually is over the surface of the body, which you can make out by the extension of the opacity beyond the thoracic cage. If this opacity would be within the lung tissue, it cannot have an extension beyond the lung tissue area. So a calcification in the subcutaneous area, often a scar which gets calcified, and or maybe a keloid hypertrophic scar which also can get calcified, they may be seen as such. Or the X-rays also could be useful to find out some anatomical abnormalities. In this, normally you will not have a cervical rib, but there could be some variations in anatomy, and in these variations in anatomy, what you can see is a extra rib over the left side, a cervical rib is seen. I think you are able to make out. So whenever you look at the chest X-ray image, you will have to have a total integral view, look at every aspect, and whether that is very specifically needed by the clinician or not. But as a radiologist, you will have to give an opinion on every abnormality which could be seen. Patient may have been exposed to the X-ray for his lung pathologies, but if you have observed a cervical rib, it's quite important that you also have to mention about it. Or the thoracic cage over the area, there could be some abnormalities of this sort, like the rib may be eroded. So now in this case, if you look at that, the fourth and the fifth rib, now to count the rib, usually the sternocostal junction corresponds to the second rib as such, and below that you have to count. So third, fourth rib, it shows an area of erosion where it has become narrowed, segment has become narrowed. So erosion could be, and erosion without much inflammatory activity. More detail of that inflammatory activity and so on, and the causes of erosion we will discuss later. But now this is just an exercise to condition your eyes to look at the abnormalities immediately. So these are all conditioning factors. Like, so that's the one which you have to make out. And there again, with the clinical history, you can confirm whether it is due to a tumor pathology, whether it is due to a previous injury or so on. When there is not much of an inflammatory activity, that suggests of a tumor activity, and it could be due to the secondaries in the ribs as such. Or there could be very gross abnormalities of the vertebral bodies which could be seen, kyphoscoliosis, very gross one, which could be seen as such. So these are all the examples are conditioning and then common features which you can see over the chest X-ray. So that's about the introduction to the chest X-ray. Now we start with the real study of the pathology of the lungs as such. So starting with the pathology of the lungs, the commonest lung pathology would be the inflammatory pathology. And the inflammation in the respiratory system can produce different sorts of the clinical presentations as well as the pathological changes. A mild inflammation, which usually descends down from the superior area, a upper respiratory tract, resulting in a lower respiratory tract infection, usually involves the bronchi, and the bronchi mucosa will be inflamed, and that inflamed mucosa would be producing some exudates, small amount of the exudates. These exudates get into the vesicles, alveoli, and that some of the alveoli may be filled with these fluids as such. Alveoli may not be directly inflamed, and this kind of an inflammation is called as bronchitis. So we use the different terms, pneumonia, bronchitis, bronchiectasis, and so on. We'll come to all that. So commonest and simplest form of the inflammation which you can see is the bronchitis. And in the bronchitis, the basic pathology would be that there will not be any gross organic changes in the lung tissue configuration. Instead, there will be some amount of the exudates flowing from the bronchi into the bronchioles and then into few of the alveoli. Some of these alveoli may be filled with the fluid, and some of the alveoli still would have air exchange. And whenever the person coughs, that alveoli may move out. These alveoli may get emptied. That the sputum which is present there could be emptied, and hence whatever the this fluid accumulated may not be constantly present. Now, this kind of a situation seen in the X-ray would be whenever the bronchi are inflamed, the thickness of the bronchovascular markings become more. It becomes slightly thickened, like what you see in this X-ray. The vascular markings, they seem to be slightly increased. Now, when you look at these alveolar structures in the windows of the ribs, we have discussed about that. You can see that there are some whitish dot-like structures, particularly seen in the right lower lobe, whitish dot-like appearances. And this whitish dot-like appearance is named as mottling in our technical term. The term used is mottling. Mottling is something like a seed is thrown over the area, and you can see some spots of that. These spots are more in the lower lobe in the fifth segment. In the fifth segment, you see more of this area, whereas the fourth segment has some amount of that. Whereas superior area, the apex area and the middle lobe area, they are free. Hilar shadows are accentuated. Suppose you have to report an X-ray, write a report on this X-ray, you will follow a method, and the method would be, the first would be, you will send, technically the X-ray is qualified, centering is proper, exposure is proper, and it's an anterior-posterior view. X-ray is taken in a partially expirated phase. It's not full inspiration. Ribs are not perfectly parallel. And the soft tissue shadows of the thoracic cage are normal. The bone cage is normal. Costophrenic angles are normal. Cardiophrenic angles are normal. Cardiothoracic ratio is within normal limits. Hilar areas, you can see the hilar shadows. A few of these calcifications in the hilar area are seen. See, these dense opacities are the calcifications, and these are present on both the sides. Hilar shadows are enhanced and calcified, and bronchovascular markings are increased, and there is an appearance of mottling in the right lower lobe involving fifth and fourth segments as such. Trachea is central. So this is how the report has to be written. So conclusion would be bronchitis. You got the point. So whenever the X-ray has to be studied and the report has to be written, you will have to start from that beginning, starting with the quality of the X-ray and all that position basic issues. Then you have to confirm that you have examined every segment of the X-ray properly. So that's the correct method of reporting of the X-rays. You are not supposed to jump at the diagnosis and then say that, Of course, in our classes, we may bypass those basic steps in future because we'll have to save time. So with every X-ray, if I go in that same manner, like every detail, it may take more time. So we'll just jump at the diagnosis, but we will not. That's not the correct method. The correct method would be you will have to have a proper method. So again, I repeat that whenever you read the X-ray, you will have to first give an opinion on the technical qualities of the X-rays, like exposure, position, and then centering. Then you will have to give the study the peripheral areas. You may come from the periphery to the center or center to the periphery, and the peripheral is usually commonly studied, like the soft tissues outside the body, thoracic cage, and then shape of the thoracic cage, the basic anatomical landmarks like costoclinic angle, cardiophrenic angle, cardiothoracic ratio, shape of the mediastinum, position of the trachea, and then the lung tissue. In the lung tissue too, you will have to comment on each segment of the lung tissue or each lobe of the lung tissue, hilar areas. These have to be noted. Diaphragm also, the surface of the diaphragm also has to be noted. So whatever the details which you see, they have to be noted down. And at the end, you will come to a conclusion like the pathology is bronchitis. So in this case, it is the bronchitis as such. Clinical signs of the bronchitis would be, usually the bronchitis would be having a insidious onset. Most of the times it's a consequence of the extension of the inflammation from the upper respiratory tract to the lower respiratory tract. So patient would have an initial history of upper respiratory tract infection, and then gradually the patient develops a cough with the scanty expectoration. Characteristic feature of the bronchitis would be cough with the relatively scanty expectoration, and the expectoration is usually thick in consistency, may not have significant varying colors, like usually it would be slight thick or maybe serous, like it could be. And the systemic symptoms of pyrexia would be of low grade. There could be not very high fever, low grade fever would be there. When you auscultate, the features which you could observe could be, there could be inconsistent rhonchi and crepitations, fine crepitations could be heard in case of the bronchitis. A fine crepitations in the involved area, like in this case, you could write lower lobe. Inconsistent bronchi in the sense whether you will be able to hear the bronchi or not will depend upon whether the bronchioles are obstructed or not. Because it is slightly inflamed and more than really the fibrosis, because the bronchial trees or bronchial vessels, tubes are having inflammation and then mucus thickening is there. The bronchi may not be consistent. At times you may hear when the patient breathes in, with certain breathing activity, you may hear the bronchi. At times it may not be. So it's not a constant bronchi which could be seen. But presence of bronchi is not a must. But presence of a fine crepitations is a must in case of the bronchitis to make the diagnosis of bronchitis. That's about the clinical history of bronchitis. So ideally, as I told in the beginning, ideally it has to go from the clinical side. You have to examine a patient. When you find these clinical symptoms, go for the X-ray. You can predict that this X-ray would have these kinds of the pathology, and then you confirm. But in our class, we go from this side to the other side. Now, some more examples of the bronchitis variations, which you can see. In this X-ray again, the technical qualifications. Now, these are the X-rays of our own hospital. If you look at the ERPMS and then search for this IP number, up to 2018, all these patients' reports are written there. So you can just have that resource. Those who are interested in studying more of these X-rays, you can refer to the X-ray images in the RPMs of our hospital in the past years of 2014 to 2018, the post 4 years duration. All the X-ray images, their reports are written, and then even the clinical history also. You can see the patient's clinical data together, and hence it can be a good teaching material also. Now, in this X-ray, technical qualification, X-ray quality is exposure is proper, but the X-ray is taken in not inspiration position, in the full almost complete expirated position. The ribs are clumping together, so that's a technical disqualification. But centering is proper, and then the trachea is central, scapula are retracted properly. The hilar shadows, particularly on the right side, the hilar shadows are accentuated, and then you can see the same